Let's see. Should I sit over there or
I think you can sit over there.
right here? Right to him or?
It's up to you.
Okay, this is fine.
And please remember, my name is Sig. I'm not...
May I call you Sid?
Yes, please.
Okay.
Okay.
Let's see. So, first of all, let me introduce you to my boss and my friends in Japan. Ladies and gentlemen, this is living legend, Dr.Sigmund Socrnsky. Could you please say hi to my boss and my friends in Japan?
I'm glad to have this opportunity to talk with you. Pleasure to meet with Jun Chen.
Yes.
And a pleasure to meet with you and by this method.
Thank you very much. I appreciate it. And again, thank you for giving me a chance to talk to you. I'm very excited to see you. And I still cannot believe that I am with you, share the time with you, sitting face to face. This is just like a dream come true for me.
You're overly kind.
Thank you very much. And I just presented some small presentation in front of you. And I wonder if you can give me some comment, honest comment.
Sure. All right. I mean, the first thing is I like what you're doing. That's an honest comment. I think that this whole control plaque that you guys have developed is excellent. I mean, the results that you show are terrific. I mean, this is clearly the right path to go on. I think that, you know, in terms of periodontal disease control, it all starts with plaque removal. I mean, by the patient. If the patient removes the plaque and does it consistently, 9 times out of 10, you're going to get a very, very good response.
9 out of 10.
9 times out of 10. Good. Now, the 10th time, it's going to probably require something beyond.
Okay.
Like surgical periodontics or antibiotics or something like that. But for most patients, that scrupulous removal has a fantastic effect. And you followed it by scaling, getting rid of the calculus. And I think that's terrific. I think that this is a terrific approach for the vast majority, but not all patients. So what you're doing is terrific. Now, about the low fat, low sugar, I'm not sure.
We're not sure yet.
No.
We just have a feeling that it could have something.
And it could be correct. I think that it's something that has to be examined with a sort of clinical trial prospective, where you sort of say, with some subjects I'm going to do this, with other subjects I'm not, and let's see if there's a difference between them. Just to get some sense of that. And I think one would use, you know, clinical measurements like redness, even unfolding, pocket depth, to sort of say, is there a better response in the individuals where they're on the low-fat diet and low-sugar diet than the other individuals. I think it would be really interesting if there was an effect. The major problem you will have in a study like that is that you'll probably be using plaque removal for those patients.
Yes.
And that does such a good job.
Yes.
That it's going to be hard to see an effect beyond that.
Exactly.
Due to the low
Yes.
fat.
That's what we are striving.
Yeah, it's difficult because plaque removal, I mean, as you show, is excellent. The results are excellent. So it's sort of like something that improves the condition by 80, 90%. Trying to see the difference for the last 10 or 20% becomes very, very difficult. It may be right, but it's very difficult. One possibility is to take some subjects and for a short term, don't do the excellent plaque removal. Just let them do what they normally do. And then do some of those with a low-fat, low-sugar diet, and others with a regular diet, and say, am I seeing an improvement in these individuals? So I think this is the type of study that you might consider over a short term, you know, like 2-3 months.
Okay.
And just to get some sense of whether this is really
Do you think it would come significant difference after a couple of months?
Yeah.
We're not really sure.
I think within 3 months you should see a difference.
Okay.
In terms of gingival inflammation and pocket depth.
Okay.
It should do that quick. Certainly you'll see a difference if you did plaque removal in that span of time. I think you would see the same type of difference with your dietary test compared to, as long as the people are not doing terrific plaque removal. As I said before, when you do that, you mask everything.
Okay.
So it should be interesting.
And in the paper of yours, I guess it was in 2006, in Hematology 2000, the title was Microbiological Goal of Periodontal Therapy, which was written by Dr. Tails, Hafuji, and you. And at the very last part, I mean the concluding notes, I remember that you wrote, what you wrote was that even though the periodontal tissue looks healthy, the subgingival area become colonized by bacterial species, and many of the species in that healthy tissue are host compatible, although a small number of the periodontal pathogens may reside in such area for a prolonged period of time and, prior to destructive periodontal disease initiation.
Yes.
And you said that the modern treatment was try to lower the periodontal pathogen to the levels approaching those present before initiation. And that could be the microbiological goal of the periodontal therapy. This is what you said. But unfortunately, that goal may be infrequently achieved because many of the subjects received same anti-infective periodontal therapy despite the recognition that the subject differ in the composition of subgingival microbiotas. And I like that. And you said that there's no one treatment fits all treatment. There's no perfect therapy. I mean, elimination of the pathogen is kind of uncommon issue. And what you wrote at the last part was many subjects respond favorably to your standard treatment protocol, suggesting that even partial reduction of the pathogen may lead to clinical benefits when most appropriate therapy is matched to your to patients to subject profiles.
Yeah.
The reduction will be much greater, and it could lead to long-term clinical stability. And I really like that. And this becomes our belief. And our standard treatment protocol was, as I told you, removal of supragingival plaque and toothbrushing instruction. And we're not really sure, but as I told you, low fat, low sugar, dietary instruction. And this is our standard treatment protocol. But we have not started the systematic antibiotic therapy because honestly speaking, we are not really sure. We are not sure if we really need that. You know what I mean?
Absolutely.
It could work. It will be beneficial from your paper. We understand.
Yeah.
But do we really need that? I mean, if we need it, if the clinical success is guaranteed with that anti-infective therapy, we would do so. But in that part, honestly, we are not really sure. And I wonder if you can tell me your honest opinion. If you think you need it, we think we want to do it, but this is what we are thinking right now.
Well, I think, to begin with, I think you did a remarkable summary of what...
Thank you very much, because I read that like 100 times.
Okay, it sounds really good, and that certainly it is the viewpoint. My feeling about the use of antibiotics is a little bit mixed, like yours. I think for just taking 100 cases of people with periodontitis and you were going to treat them, I would think that probably about 60 to 70 of those cases would respond very well without antibiotics.
Okay.
And that probably just giving sort of, here's a combination, say, of amoxicillin plus metronidazole, then just sort of arbitrarily giving it to people, probably another 15 to 20% would respond really well, in addition to the 60 to 70%.
Okay.
And you're still going to have 5-10% maybe that are not going to respond very well. The problem I have is which one of those people really would benefit from the amoxicillin, let's say, and metronidazole. Because that's the quandary that we have. I couldn't look at a patient, either clinically or even with their microbiological data, and say, this one needs amoxicillin and metronidazole, this one does not. I couldn't do that. Right at the moment, it's a probability game. That is to say, I know that if I give this to everyone, there'll be a small number that get additional improvement beyond what they would get with scaling in the clinic and home care. And the difficulty I encounter is I don't know which person that is. And so antibiotics, it's easy in a clinical trial. We can show that antibiotics do help, but we can't say for who. I mean, you see, it becomes a probability game. If we treat 100 subjects with them, we're probably going to get somewhat better results than the 100 subjects we treat without antibiotics. But who would gain the most? I don't know. And that's why in clinical practice, it becomes very difficult. You're sort of saying, I know that the majority of people are going to respond well without antibiotics. I know that a few more will do well if I added antibiotics. But is it worthwhile to put the patients at risk because of the side effects of antibiotics just to get that extra, a few patients that will respond better? And at the moment, I'm 50-50. That's not very helpful. Okay. But I am 50-50 on this issue. If I were in practice, probably my personal guidelines would be that people with very advanced disease, particularly younger individuals, I would give antibiotics to them. Just because you don't want to have these people to continue to break down. So you sort of say, they are sort of at risk for losing teeth if I don't do something. So I would probably give them antibiotics. Somebody in their 50s, 60s, 70s with not too much disease, I would not. I would say I could probably achieve this with home care, scaling with blade, proper.
So you don't give antibiotics to anybody?
No, I don't give antibiotics to everybody. No way. Oh, absolutely not. I would think that the clinic here, the people that we treat not in studies, I would say that probably at most 25%.
25?
At most. Might get
1 out of 4.
Yeah. Would get antibiotics and the others would not. I mean, it is, because we do a lot of studies on antibiotics doesn't mean we sort of give it to everybody. We do not do that.
To what kind of patient do you give antibiotics, like refractory periodontitis or
refractory periodontitis? Yes, that's people who fail to respond to conventional therapy. Young people who have a lot by young I mean under 35.
Okay.
And they have a lot of disease, and I feel that these individuals might, might continue on and lose teeth. Give them antibiotics as well as the scaling routine home care.
Okay.
In addition, and probably people who smoke. Smokers are very difficult to deal with, and antibiotics, particularly combination antibiotics, like amoxicillin plus metronidazole, that helps somewhat in smokers. They're more difficult to treat. But those three groups are the three groups that we would probably give antibiotics with, sort of without knowing anything else about the condition. Like if we were just sort of saying, clinically, here are some people, who would you treat, who would you not? It's the refractory, the young with aggressive disease, and the smokers.
Okay. Thank you. I was kind of misunderstanding. I thought you prescribed to anybody.
Oh no, absolutely not.
Okay.
We would not do that.
Because I thought that was kind of your standard treatment for all.
No, not at all.
Okay.
No, like the majority of patients, we would not give antibiotics. And, I think it's safe not to, which is good. I'm glad we clarified that.
Yes, it's become clear. Thank you very much.
Good.
Okay. May I ask you another question? I guess it was in 2004 in Dr. Harper's newspaper. She reported subgingival microbiota in different locations. Different geographic locations.
Yes.
And I guess it was USA, Sweden, Brazil, and Chile. Am I right?
That's correct.
And she found out remarkable differences.
Yes.
And unfortunately, none of the Asian country was included in that report.
It's unfortunate.
Let me say, if any of the Asian country was in that group, what will be your expectation or anticipation? Okay, let me ask you this way. Do you assume that there is a difference in races?
I'm not sure whether it's races or whether it's geographic location. I don't know. Why I say that is that I'm not sure first of all, there are differences in geographic locations in the composition of sublingual microbiota. That is clear. I don't know whether it's because of genetic background, which implies races, or whether it's things like cultural practices,
yes.
Like how often they brush and what they eat and when they eat and that type of thing. Whether it's a community effect, because people pass bacteria around in their community. So over time, one community may get an enrichment of certain microorganisms, and another community may have an enrichment of other types of microorganisms. And that's not necessarily racial or ethnic. It may well be just simply that these are the bugs that in this community overgrew and became dominant for a particular group of individuals. So we don't know that it's racial or genetic. My suspicion is that the most important factor is this effect of transmission in a community, and that the community is showing this pattern of colonization. This is something, by the way, we would like to test, and that is, like you sort of say, would different American communities, like Boston versus New York versus Los Angeles,
yes.
Do they, with the same ethnic grouping, do they show differences in their microbiota? My guess is they would.
They would.
They would. Yeah. The only reason I say that is that a while ago we looked at some localized juvenile periodontitis patients in the Boston area, and their microbiotas were different than those in the Ann Arbor, Michigan area of the United States and the Atlanta area of the United States. So, even the same disease, but in different locales, have a somewhat different microbiome. So I have a feeling there's a big community effect. But, other factors like race, diet, certainly play a role.
Okay. I'd like to know about it.
So would I.
Please. I'm looking forward.
Yeah, I think it would be a terrific study, and I'm hoping that Dr. Nafferty can get that study going. It would be good.
That would be great.
Yeah. And I think, if one looked at an Asiatic community, my expectation, again, would be that they would have similar species as the other communities. It's the distribution of the species that would be different.
Okay.
Like, so, for example, Tannerella forsythia might be high in one group and low in another, but P. gingivalis might be high in this group, but not in that group. But all of them would have very similar species. So an Asiatic community would have similar species, but the portions that the species had in each individual would be different from community to community.
So we'll be looking forward to
That would be
next research of Dr. Haji.
Yeah.
Okay. And this is what I really wanted to ask you about future prospect of microbiology. And in some paper, I guess it was in the same periodology 2000, microbiome ecology.
Yes.
At the very last part, I really like that comment of you at the section of what's new. And that sentences were difficult for us, but what we felt was, in the microbiology specific field, like which species does the bad thing, or who does the bad thing to the periodontal tissue. We have a feeling that the research itself is kind of deadlocked. I mean, correct me if I'm wrong, okay? And we are looking for a next vision. I mean, do you feel that you need to change your strategy, or what kind of future prospect do you expect? Do you know what I mean?
Yeah. In terms of microbiology or in terms of clinical?
In terms of microbiology.
Well, in terms of microbiology, as you probably know, there's a lot of emphasis on uncultivable bacterial species right now.
Okay.
That is, the species that you can't grow, but by their DNA signatures, you can tell that they are there. And, there's maybe 30-40% of the organisms in subgingival plaque really are not cultivated at this time, but can be identified, and they can actually be quantified. But their role in disease is unclear. So certainly that's one area that's going to be expanded. But for me, the interesting thing is trying to understand the relationships of these species to each other and to their habitat, the place that they grow. This is a little bit of an aside, but before I got ill, I did an awful lot of mountain climbing. And I was always fascinated by the vegetation that grew on the mountains and how it changed from one elevation to another, from one place where there are rivers and streams to places where they are dry. All these differences in combinations of trees and plants and so on. And you see the same type of thing in the microbiota. That the microbiota, for example, high on a tooth, away from the gingival margin, is different from the one next to the gingival margin because the habitat is different. the environment in which they live. And so you see one type of community high on the tube. Next to the gums, you see another type of community. If the gums are inflamed, the community of microorganisms changes in composition. If you go under the gums, it changes in composition. A thin plaque has a different composition from a thick plaque. And so what one is seeing is ecosystems that are altered by their habitat and changes in the composition of the clouds that are there. Now this is really important clinically because depending on the composition of the organisms that are there, you will or will not get disease. Okay, certain compositions are compatible with the patient. Others are clearly not compatible. Now, where I see microbiology going is the purposeful alteration of the composition of the microbiota. Sort of saying, instead of letting it occur by random chance, let's change it. Let's direct it to one where the species are compatible with the individual that they colonize. And I think that can be done. I mean, we already have clues as to how to do something like that. I mean, we know, for example, what scaling and root planing will do to microbiota. We know that it may typically affect like 3 species, Tannerella forsythia, Orphomonas gingivalis, Treponema denticola. So we say by doing this mechanical procedure, we can change the proportions of these particular species. By giving a certain antibiotic, we can change the proportion of other species. By giving anti-inflammatory agents, again, we can change the composition of the microbiota. So what I'm driving at is I think in the long run, we're always going to be colonized by bacteria. They're always going to be in our mouth. For all our lives, no matter what we do. The strategy in my mind is to change the composition of these organisms to one that the host can live with without getting disease, either caries or periodic disease. And so to me, this is where microbiology will go. Is, okay, we understand, we're beginning to understand these different communities. We're beginning to understand where certain kind of communities live in this environment. Now, how can we go about changing the composition of that community to one that we would like to have in our lives? And I think this is where we're going. And by the way, I think this is quite feasible. I think it can be done. It is, because it's not requiring huge changes in the host. We don't have to genetically modify the host or something really, really outrageous in order to make these changes. We can make the changes without harming the individual. Even what you showed me, where you were doing plaque control so vigorously, I mean, this was having a tremendous effect on the composition of the microbiota. You changed the community structure tremendously by what you guys are doing with your patients. And so you can do that with that, and then you can add to it other means to alter the composition to one that allows long-term stability.
Let me tell you this. In my country, most of the dentists regard our group are kind of weird because we're just teaching a toothbrush and they know that it doesn't make any money. You know what I mean?
Yeah.
So most of them regard us like a weird group. But this is what we believe. We are not working to make money. We're working for the patient's health.
Sure.
So this is our belief.
Yeah. Well, I don't think that's weird at all. I mean, this is the goal. The goal is to control the patient's disease, to give them, as you know, better than I, best possible function with the least possible consequences and side effects and pain and discomfort and everything. And one of the best best means of doing it is certainly back control.
Yes, exactly.
Everything starts there.
Yes.
This is the beginning
Absolutely.
of control of the disease in every subject. I mean, this is so important, and it's not weird. It should be the first thing on the dentist's list of things to do. This is where I would start. If I were in practice here or in Japan, the first thing I would do is set up a plaque control book. Begin there, and then go on from that point.
I'm so happy to hear that.
I'm happy to say it. I'm happy to believe it. I really believe that.
I imagine that you would say, you guys are crazy.
No, I wouldn't do that. You know, periodontal diseases are infectious diseases. They're caused by a group of microorganisms. The primary way of controlling infectious diseases, whether they're in the mouth or in the body, it is always by sanitation. I mean, in this community of Boston, the most important way to control infectious disease is by washing, by flush toilets, by sewer systems, by keeping the load of the organisms down.
Okay.
It's the same thing in the mouth. It's sanitation.
Sanitation.
You lower the number of organisms in the mouth, and then the risk for disease to the subject is decreased dramatically. A small number will get it, you will use other means to deal with it. But that is the key starting point. And if you don't do sanitation, let's say in Boston, they didn't have a sewer system. They didn't have, hand washing and cleanliness and so on. You can imagine how much worse disease would be. All kinds of diseases. Lung infections, GI tract infections. That's the same thing. This is the key way to control disease in any environment. And the mouth is no exception.
Okay.
Okay.
I'm glad to hear that. And we will be looking forward to another paper of your group